Hey everybody, a few housekeeping issues before we get to the episode. Number one, I would like to thank Dr. Kate Grant for her beautiful cover art, Dr. Cyrus Askin for helping with the show notes and the CME package for this episode, and Sarah Phoebe Roberts, our fearless producer for this episode. I would like to announce that there is CME and mock credit available for ACP members. You can visit www.acponline.org/Curbsiders to claim your CME and mock credit. And finally, I would like to say that the audio quality for this one is not our best. It was a live episode, so we are at the mercy of the acoustics of the room. We do have a bunch of future live episodes coming up, and we have ideas on how to make the audio better for those, so please bear with us for this one. The audio is definitely still passable. Thanks again to all the folks at Chess for bringing us to this conference. And without further ado, here is our live show. So welcome back to the Curbsiders. This is a live podcast that we're doing from Chest 2019 in New Orleans. Thank you all for coming. And before we get into things, I guess we should tell you who we are, since you're probably used to our voices, but maybe not seeing us in person.
We actually have a disclaimer first.
Oh, you want to read a disclaimer?
I don't really want to read it, but it's there.
I think you should read it as fast as you can.
The Curbsiders podcast is for entertainment, education, and information purposes only. The topics should not be solely used to diagnose, treat, cure, or prevent any conditions or illnesses. Furthermore, the views expressed are solely those of the host and do not reflect any official policy or position of any entity aside from possibly Cash-like, Moral, Hospital, and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your homework and let us know when we're wrong. We have no conflicts of interest, and we have no financial disclosures. Is that true?
That is true.
That is true.
So that, of course, is the great Dr. Stuart Kent Brigham. I'm Dr. Matthew Frank Watto, and of course, this is the great Dr. Paul Nelson Williams.
Of course, really the reason you're here this morning.
Yeah, Paul has a lot of fans.
Sure.
So he also likes hugs. So after we're done today, please give him a hug.
All true.
Take a picture with him. We are going to be talking all about sleep medicine with Dr. Christine Wan. But before we get into that and read you her bio, Paul is going to tell you what it is we generally do on this show.
Paul, what do we do?
It's such a great question every time.
Why are we here? Why are we here, Paul? What is the meaning of life?
More importantly, why are these people here? We are the Internal Medicine Podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. We claim to have an international team of over 20 correspondents.
Claim.
We do. There's one in England and there's one in Cambodia, so we're calling it.
Yep. It's kind of like an international airport, as long as they have one flight going outside.
Yeah. I think we get to count it. We hopefully are using up-to-date insights and use multimodal learning, so it's not just the podcast. We have show notes, there are videos, and it is 100% free. These are some recycled jokes, but if you're paying for it, then someone is scamming you.
Okay, so before we get started, I just want to let you know that you can live tweet if you happen to have a Twitter account. You can tag at the Curbsiders and hashtag Chess2019. We actually have someone that is currently, looking at the account, or anyways. So managing, sure.
Good stuff.
Bonus points if you use hashtag Curb19. I don't know what those bonus points mean. It's kind of like, whose line is it? Okay, so what do our show notes look like? We have algorithms, we have title cards, and we have different show notes that include pre-test, post-test questions. They come in different forms and formats. They are emailed to your inbox. There is a QR code at the end of this presentation that you can point your phone at to be signed up with to the mailing list. We also have infographics, and we have several different graphic artists that work with us to bring to you these nice little cards that you can print off and put into your office or hand out to residents. We also have some snarky humor as well. So as you can see here, we have one that says, "On the 7th day of Christmas, my true love gave to me herpes." And that goes through 1 through 7, some things to remember about herpes. And then we have, this is from Dr. Kate Grant in the United Kingdom, who does a lot of cartoon art and also does paint, which is why her handle is at KatePaint42. Very nicely done. They're all referenced and sourced. And the best way to reach out to us is through Twitter. So without further ado, I just want to let you know, our episode today is Sleep with Dr. Wan. There are some things that we don't cover. This is in separate episodes in the past. We've got episode 116 that covers this with geriatric psychiatry, sleep, dementia, and behavioral disturbances. And another one, episode 12, which is specifically insomnia.
Exactly.
Okay, so without further ado,
Yeah, and I think we wanted to point out just much respect to you hardcore types who are coming to a sleep talk at 7:30 in the morning, and the pulmonary critical care types who actually have 5:30 talks. Like, that is bonkers. I intentionally did not become a surgeon.
This is,
and yet here we are.
This is actually the second conference we've gone to that there's been a sleep talk at like 7:30.
Yeah, that's very.
I feel like
true.
they're saying something.
But rather than complaining, how about I be thrilled to introduce Dr. Christine Wan. I'm going to tell you a little bit about her. She's the director of the Women's Sleep Health Program. She is a board-certified sleep specialist who's also trained and certified in pulmonary and critical care medicine. Her areas of clinical and research interests include complex sleep-related breathing disorders and sex differences in sleep-disordered breathing and hypersomnias. Dr. Wan is the director of the Yale Sleep Laboratory. She is the associate program director for the Pulmonary and Critical Care Fellowship Program. She is chair of the sleep-disordered breathing section of the American Academy of Sleep Medicine, member of the National VA Sleep Network, and sits on the board of directors of the Connecticut Sleep Society. Dr. Wan received her medical degree at Albert Einstein College of Medicine and completed her sleep, pulmonary, and critical care and undergraduate training at Stanford University. And without any further ado, we are thrilled to introduce Dr. Christine Wan.
I'll let you sit down so we won't both fall off the stage here.
Oh, wow, yeah, that's pretty...
Yeah, just be careful. Don't move your chair too far to the left or we might have an emergency. But we will be well prepared to handle it if that's the case. All right.
Thank you.
Thank you for joining us. Dr. Wan, is it okay if we call you by your first name moving forward for the interview?
Yes, please do.
All right. Christine, please give our wonderful audience and listeners a one-liner about yourself and tell them a hobby or interest outside the world of medicine.
Oh, great. Okay. Well, first of all, I want to say there's this big picture of me plastered on the screen. I've never seen myself 6 feet big there, so that was kind of interesting. I am a mother of 2 young children, 2 wonderful girls, one of them who's going through this pre-adolescent angst that I'm dealing with. So to cope, I've been taking Taekwondo, and I'm currently working towards my black belt, so we'll see.
Oh, amazing.
Yeah, stress relief.
Maybe I need... How long has it taken to working towards a black belt?
So I've been doing it for about 3 years, and I'm working towards that black belt.
That sounds fun.
Yeah, it is. Sparring.
Is that your next goal, Paul? Or Paul? Is that your next goal, Matt? You've only been doing this for 4 years.
To become a black belt?
Yeah.
Well, I mean, it was always a goal.
Sure, as of this morning, yeah.
I'll defer to you, gentlemen, if you wanted to ask any questions of our esteemed guest.
Paul?
Sure, I'm amassing book recommendations, so I'm going to ask, and it doesn't have to be a medical book, but just a book that you think most physicians should read or at least would enjoy. Most things.
I'm sorry to say I haven't picked up a leisure book in probably a year or more, but I can tell you on my to-read list, I have a couple of books that I'm trying to get some time to read. My colleagues have been very, very prolific, and they've just recently produced a couple of books that I'm eager to read. Dr. Schneeberg, who's our child psychologist who also does CBTI, she just wrote a book called How to Become Your Child's Sleep Coach. And then Dr. Krieger, who also works with me, he just wrote this interesting book about how artists depict sleep throughout history, and I'm eager to pick that up too.
Excellent. Right. One of my favorite questions is about favorite failures. It can be anything in your own personal or professional life that you've learned from a patient complaint to a death or something that has happened. What's your favorite failure and what did you learn from it?
Yeah, that's an interesting question. And actually, you're not the first person to ask me that question. And interestingly, when I was asked this question, I was with my younger daughter, and someone said, "Well, what's your favorite failure?" And I thought about it. I couldn't really think of one. And then my daughter, tugs at me and says, "I know what your favorite failure is." And I asked her, "What is it?" She said, "My sister."
Burn.
Yeah.
All right.
Wait,
What'd you learn
did
from
you
that?
agree with her? I lost the thread.
And then we high-fived. It was great. It's really...
I didn't agree with her.
Another thing we like to ask, because a lot of the people, ourselves and a lot of our listeners, are either trainees or interested in going into education. What is some good advice you've gotten along your career? And it can be at any level, when you were a trainee or now that you're an attending physician.
I think I've gotten a lot of good advice from colleagues throughout my career. I think one of the things that I do follow by is to pursue your passion. As silly as that sounds, I think that's what makes you do great and succeed, is if you enjoy what you're doing. So I never do anything that I think I wouldn't be passionate about.
Yeah. I think someone said it a little different way on the show recently. It was like, if something's not worth doing well, then it might not be worth doing. Well, Paul, Stuart.
Speaking about doing well, do we have picks of the week?
Yeah, I think we do have some picks of the week. I think we can get on with that. So I believe Stuart predicted what our picks of the week would
That's
be.
right. I was trying to see if I knew you guys well enough.
So which order are we going in?
We're going Paul, you, then me. Okay. All right, so Paul, here are your options for picks of the week. Okay.
Stoked.
Either The Toxic Avenger.
Great.
Okay. Or The Adventures of Buckaroo Banzai. So which one would you like to talk about?
It's
By the way, I picked these without even talking to him. He had no clue.
So I think solid picks both. I think I'm going to recommend Toxic Avenger. I feel like that's sort of the flagship property of the Troma Studios, run by Floyd Kaufman, which is sort of a punk rock movie making sort of studio that broke conventions but still actually cared about cinema history. So I think if I had to pick one, I would probably go with that one, though Buckaroo Banzai has its adherents. But yeah, so please recommend the Toxic Avenger as my pick of the week. Thank you so much, Stuart.
By the way, he had no clue. All right, so Matt, your choices are a podcast, You're Dead to Me, or jump ropes.
Well, I mean, in that case, I'm definitely going to pick the jump ropes.
Yeah.
I definitely jump roped, not yesterday, because I should have brought it with me, Paul. It's actually very travel friendly, so I should have brought it with me, but I did not. I would pick the jump rope, but my real pick of the week, so Halloween is coming up soon, and my kids are recently obsessed with Weird Al Yankovic, which,
that's right.
Yeah, it still holds up a little bit. There's some questionable lyrics in there, but overall, it's a fun listen. And I will be Weird Al for Halloween. I ordered a wig and a wacky shirt. It's going to be a great time. I'm really excited about Halloween now.
All right, and in the interest of what this podcast is about today, sleep, my pick of the week is My Pillow. No, not that one. Actually, My Pillow from last night. So just want to let you know, My Pillow has a patented fill, keeps my neck pretty much straight, and so I can wake up and at least feel a little bit rested. So if you want My Pillow, you can't have it because it's My Pillow.
Good stuff.
All right, I totally lost track. Paul, what are we doing?
Why don't we transition to a case? I think we're going to have Stuart talk us about a name that we're not even trying anymore with.
Yeah, that's right. It was Mr. S. Andaman. Well, it's actually Mr. Sandman, okay? So Mr. Sandman, he's a 53-year-old male. He's got hypertension, obesity, diabetes. He's seeing us for follow-up in primary care. He reports overall poor energy levels, and he'd like us to check his testosterone levels. You see, now he works in IT and sits at a terminal all day long. He eats the standard American diet, the SAD or SAD diet.
The SAD diet.
What does that stand for?
The standard American diet.
Oh. Okay.
The standard American diet is the SAD diet.
I see. Okay. Well, I walked right into that one. All right. While he was a previously well-known boxer in the 1980s, now his only physical activity is yard work on the weekends. He goes to bed at midnight and wakes up around 6:30 a.m. So before we get started, and before we start picking on Mr. Sandman and his messy sleep habits, let's take a step back and just to kind of answer the question, why in the world do we even sleep?
I think that's a great question. I think that's a question that we've all been struggling with as sleep scientists. There are several theories out there, quite interesting ones. I think nothing that's been sort of panned out as definitive, but I can share them with you. So one theory is that it's evolutionarily beneficial for us to sleep. So, for example, the inactivity and the energy expenditure theory. So, maybe way back when it was evolutionarily beneficial for us not to walk out in the dark, because, we could hurt ourselves. We could be, at risk predators, mosquitoes and bugs and whatnot. So maybe there was a survival advantage to being dormant or sleeping during the night. More recently, I think we're looking at more biological reasons for sleep. So, for example, there's the restorative theory, the thinking that we build up toxins or biological leftovers through all our activity during wakefulness, and as a result, we need some time to clear those things, those toxins, the byproducts, and that might occur during sleep. So, for example, we know that the relationship with Alzheimer's disease, the increase in tau protein that's found in CSF when you don't sleep, we think that that's extracted from our brains when we do sleep. The other theory is the whole brain plasticity theory, the fact that maybe memory is consolidated while we sleep. So, for example, during the day when we're, up and around, we have a lot of stimuli coming towards us, and our neurons are firing, they're making connections. But we can't, store all that knowledge. We have to really be selective, from a survival point of view as well. And so the thinking is that, when you go to sleep, there's a lot of pruning going on with the neurons, so that only those memories, those neuronal connections that are important are left over or are strengthened during your sleep, and so that helps with memory consolidation as well. So who knows what sleep is for? But it seems that there is some biological necessity. I mean, we sleep a third of our lives, right? We live 75 years, and 25 of those years we're spending in sleep. So it must have some important biological function. I think we're just trying to determine what that is.
But we know it has impact. So I guess it's funny because we're framing this conversation like we're trying to convince this patient that sleep is important, whereas I don't think I've ever had to convince my patients that largely. But if you were going to talk to a patient about why sleep's important and how it impacts your sort of overall health, what would you tell to Mr. S. Sandman or Mr. Sandman?
Yeah, sleep is definitely important to our health. I think it gets lost in a lot of our primary care or care that we give to our patients, but sleep has been associated with, or lack of sleep, I should say, or poor sleep has been associated with a lot of health detriments, especially cardiovascular disease, metabolic disease, weight gain, hypertension. There are a lot of epidemiologic studies that suggest that if you're suffering from insomnia or if you're a short sleeper, so for example, in the Penn cohort, they followed patients for about 7.5 years and found that those who were suffering from insomnia had a greater risk of developing incident hypertension. Similarly, there was a Norwegian study of over 50,000 patients, and they followed them for 11.5 years. And these were patients who were naive to cardiac disease. And what they found was those who were suffering from insomnia, plus having short sleep hours, were 4 times at risk for getting an acute MI.
They have a sense, I had a question about that, especially with the cardiovascular risk. Do they have a sense of how much of that is attributable to maybe undiagnosed or underdiagnosed OSA?
Yeah, that's a great question. You never know in these epidemiologic studies because you're not necessarily studying all these people. OSA in and of itself is associated with cardiovascular detriments, so certainly that could be one mechanism. If you have OSA, you might have poor quality sleep, you might suffer from insomnia, you might have short sleep hours. All these things might propel into this poor cardiovascular outcome. But studies have suggested even without OSA or concomitant disease that just having short sleep can be a risk factor for cardiovascular disease. It's also a risk factor for weight gain, we know, and metabolic disease as well, like insulin resistance.
So this morning I woke up with some cold-like and allergy-like symptoms, and I didn't sleep really well last night. Is there an association between like poor sleep and common cold type symptoms?
First thing I want to ask, were you out late last night?
No.
Okay.
That's not me.
No, New Orleans. Okay. So, there is a theory that poor sleep, adds to poor immune function. We think that, some of the like TNF and IL-1, these are immunomodulators that they're secreted during sleep and may help us fight off infection. And with the lack of sleep, we may be dysregulating our immune system.
Yeah, the study that I had seen on the common cold, it was in Journal Watch within the past few years, and it was that you were just as likely to, I think they were infecting people with, purposely exposing them to rhinovirus.
That sounds horrible.
People were 4 times more likely to have symptoms of rhinovirus if they were sleep deprived.
Less than 6 hours.
There was the rate of infection wasn't different, but the sleep deprived people were just more likely to experience symptoms, which I thought was interesting.
That sounds like a horrible trial.
It is a horrible trial. Who signed the consent form on that?
I don't know.
It's probably med students.
Yes, the IRB was sleeping on the job.
Yeah.
Was that on purpose?
Yeah. You're better than that.
That was something I'd say.
But I think with this patient, Mr. S. Andman, his I think maybe as far as carrot and stick type things, he's interested in testosterone levels. How do you, when you're talking to a patient about sleep and trying to convince them, or when you're talking to a patient about, in the primary care office, it's very common for people to come in and be like, I feel like crap, I want testosterone. As a sleep doc, how might you answer that question?
Well, I would promote sleep because actually testosterone levels are associated with sleep duration. So testosterone is secreted during your sleep. It starts peaking about 3 hours into your sleep, and then it probably peaks maximally at early morning hours or so. And studies have shown that if you're sleep deprived, particularly in the first 3 hours, so you have more of a sleep onset type of problem with sleep, then your testosterone levels are much lower. So enhancing your sleep may enhance your testosterone. And as you mentioned before, sleep disorder breathing, or OSA, has also been associated with low testosterone levels. But actually, studies have found that it's not really the sleep apnea per se that causes low testosterone. It's actually obesity. So obesity and OSA often go together, and that's why we think that it might be associated. But actually, losing weight increases testosterone, and CPAP, that has really been equivocal in terms of testosterone levels.
So we're talking to Mr. Sandman, and he's not sleeping well during the week, but he feels like he's probably doing okay because he sort of catches up on the weekend. So he sleeps until 10 o'clock, and he wishes that he was more like his wife, who apparently can sort of function on 4 to 6 hours of sleep a night. So
her name is Mrs. Andman? Is that?
I hate this so much. I'm so angry right now. So I guess 2 questions in terms of when you're counseling patients, how much sleep should they be getting, and then can he catch up? And I think we know the answer, but if you can sort of speak specifically to how unfortunate he is, that would be helpful.
Yeah, so the ASM, the American Academy of Sleep Medicine, and the Sleep Research Society have produced these guidelines of suggestions of amount of sleep. And for adults, it's generally recommended that we get greater than 7 hours of sleep every night. It differs with children and adolescents. They obviously need much more sleep. And sleep is a bell curve, the sleep hour need. We say on average normal healthy people might need 8 hours of sleep. But there's some people who do fine on 7 hours, perhaps even 6 hours. And there are also those who need more hours of sleep, like myself, 9 hours at least. Or maybe even 10 hours. But I think what we know is that the sort of tail end of that bell curve, maybe less than 5 hours, greater than 10 hours, I think that's pathologic, and we have to look for either sleep disorders or we know the consequences of the short sleep time.
And can he catch up? So can he bank on the sleep on the weekend and sort of undo his sleep debt?
Yeah, you're exactly right. So sleep, the process of sleep is twofold. One is, acquiring a sleep debt. The longer you're awake, the more sleep drive you have. But it's also a homeostatic function of your circadian rhythm. Nighttime and daytime, there's a 24-hour, promotion of sleep and promotion of alertness. You can function by banking on sleep. There is some studies that suggest that if you try to keep healthy sleep schedule, maybe get a little bit more hours of sleep or prophylactic naps, you might perform better or do better even with a night of sleep deprivation. But just to know that sleep deprivation is cumulative, so you have to make it up at some point.
But so are you saying you can make it up? Like, let's say that I sleep on weekdays, I sleep 5 hours a night, and then on weekends I try to sleep 10 hours on Friday, Saturday night. Does that have like beneficial health effects? Am I catching up, or is it just? Am I just
just theoretically here? Just
what do you want to hear?
No. Tell me. I just be honest. Just be like.
So give it to me straight, Tom.
Yeah. Well, the weekend catch-up sleep is actually a reflection of your poor sleep during Monday through Friday. That's
right.
What it really means. It's not that you're going to do better on Saturday, Sunday sleeping 10 hours. You're going to do better Monday through Friday per se, but just the reflection that you really lost some sleep during your weekend. So. You should feel better. We call this actually social jet lag. So what happens is that on the weekends, people are staying up later, waking up later, and then Monday comes around, time to go to work. You have to change your schedule. You have to go to bed earlier, but it's a little bit more difficult because you've been sleeping in, you've been sleeping later, and then you have to wake up earlier as well. So you feel crappy Monday, Tuesday. You might start feeling a little bit better Wednesday, Thursday, but then Friday comes along, and then now you're doing your rotated schedule again. So that's what we call social jet lag, and we actually, it's very common in adolescents, for example. And we try to counsel, parents about, how detrimental that could be for their performance and health.
You mentioned having young daughters that are kind of getting into the teenage years. I don't know if they're exactly teenagers yet, but as far as teenagers and sleep, they tend to want to stay up later, right? But then they have to wake up earlier for school. As a parent, I'm sure there's lots of parents listening. Is there any specific tips or any approach you have to kind of that circadian rhythm issue? in teens?
Yeah, I think one societal misunderstanding is that, teens are like mini adults and they only need 8 hours of sleep. Actually, they need much longer hours of sleep, at least 10 hours, maybe even up to 12 hours of sleep, surprisingly. And adolescence is a time where a lot of them become phase shift delayed, so they start wanting to go to bed later and waking up later. That's sort of their natural rhythm that has developed. And unfortunately, society doesn't work that way, and school starts very early in the morning.
Right.
They have to get up, but then you also have people, they have homework, they have, school activities, they have social activities, they have electronics that they can do all night. So they end up staying up later. So, adolescents are frequently sleep deprived. My suggestion would be, to obviously avoid electronics during the nighttime, try to develop a routine sleep schedule, be firm about the bedtime. Having said all that, there are people who are really pathologically delayed. I mean, they really suffer, and as a result, their school suffers, their social life suffers, they develop depressed mood. And those patients we actually take in and actually do some therapy to help restore their circadian rhythm or advance it. And we can do that with melatonin, we can do that with light therapy. These are highly effective ways, and it's actually really quite effective and easy to shift somebody's circadian rhythm. You just have to be pretty disciplined about it.
So you're shifting them where they'll have a more normal bedtime, 9 or 10 o'clock, something like that, instead of 11 or 12 o'clock at night. So that way when they're later, having to get up at school for 8 a.m.
Yes. Actually, California I don't know if the audience knows, but recently passed a law that prohibits middle schools from starting before 8 a.m. and from high schools starting before 8:30 a.m. And it was really driven by initiatives of some sleep specialists up in Stanford, actually, who really advocated for these late school start times. And I think, there's a movement towards that because we see how detrimental it is to our children.
Yeah, I heard some of the wider adoption of that has been prevented by just the flow of society, as you already referenced. Like, if you have some kids that are starting school at 8 a.m. and then your high school kids are starting at 10 a.m., it just kind of throws off mom and dad getting to work and whatever.
Yeah,
so it's
absolutely. There's a lot of resistance for practical reasons such as that.
Right.
Who's going to watch my kid early in the morning? I have to drop them off. And they have sports as well, and that gets delayed, and then they can't compete with other teams because they're off on their schedules. So there are a lot of practical barriers. But I think we have to balance, or there has to be a cultural change, actually.
Well, fortunately, in the next part here, I think you're going to just tell us all about how we can fix this. So,
sure, no problem.
Mr. S. Andman, he tells you, you know what, Doc, at night I just kind of sit there thinking about all these stressful things going on in my life, and it's just so much easier. It helps me a lot. I take some diphenhydramine. That makes me drowsy. Usually chase it with a beer or some wine. And that's the only way that I can fall asleep. So how do you counsel patients about that when they think they're getting better quality sleep by using these agents that make them sedated? Does that actually translate to better outcomes?
Yeah, that's really a very common scenario, people self-medicating for sleep. In terms of my counseling and what I tell these patients, I don't resort to these sedatives, certainly not to alcohol, for improvement in sleep. Actually, the first line therapy recommended by, again, the ASM, or the American Academy of Sleep Medicine, as well as American College of Physicians, is a CBTI, actually, cognitive behavioral therapy. That's probably the most effective means of treating chronic insomnia. So I would actually ask him not to take these things, especially over-the-counter medications, which have, the antihistamine effect is what makes people drowsy, but it also has a lot of, anticholinergic effects that could be toxic, in the future, produce palpitations and jitteriness and things like that.
All the society guidelines seem to also recognize it's really challenging. Like, first line is CBT, but then also it's almost impossible to get people into CBT. Yeah. So what resources do you have for patients who maybe are having trouble sort of getting an entry into someone qualified to give them CBT? Are there any at-home resources they can use?
Like online CBT type things?
Yeah, there is a movement toward online CBT because exactly for what you say is this axis of care. I mean, CBTI is an intensive program. It's not just a one-time visit, hi and bye. It's 4 to 6 weeks of intensive contact and coaching. And like you said, even in our sleep center where we have a dedicated person doing this, I mean, she's months backed up.
Sure.
So it is hard to get people into this. So they have been developing online CBTI, and there are actually some studies to suggest they're quite effective in treating chronic insomnia. So shut-eye is a common one, if you've heard of that. Sleepio.
Oh, yeah.
Yeah, Sleepio. Have you heard of that? And there's a free one actually put out by the Veterans Affairs Association, or Veterans Affairs VA.
Yeah.
It's called the Sleep Coach, and you can download that and use that. So there are resources, certainly. I think if it's a significant problem, you should probably seek help or assistance coaching with a professional. But yeah, CBTI online is the way to go.
And I feel like we lean heavy into the sleep hygiene thing. So I guess two questions is if you had the one absolute, the thing you must do or you must not do in order to sleep, what is sort of your favorite sleep hygiene tip? And then the follow-up, I guess, is a lot of times patients come back to me, yep, I tried all that, doc. It's still not working for me. So I'm curious to what the evidence actually is behind sort of the sleep hygiene things that we recommend. I don't know why I use quote here. Sit on my hands. The sleep hygiene things that we recommend.
So sleep hygiene, yeah, that just basically sums up, the kind of basic proper sleep promoting behaviors you can do at home. So, avoiding screen time, dim light, having a bedtime routine, doing relaxation exercises prior to sleep, avoiding caffeine close to bedtime, doing your physical activity as much as possible earlier in the day, avoiding naps. I mean, these are what you call basic sleep hygiene. And everyone should do that. I mean, I think it promotes good sleep health. In terms of the evidence behind treating chronic insomnia, unfortunately, sleep hygiene alone is insufficient to make a difference. And in fact, even a lot of CBTIs will bypass sleep hygiene, assuming that, you've already sort of been educated about that and you sort of are on the road to do that. So sleep hygiene is something that can improve sleep in people who are already good sleepers. Sleep hygiene can also help people with acute insomnia or situational insomnia, something that's aggravating them for the day or the week. But for chronic insomnia, you really need to do a formal CBTI program to get an effect.
So you mentioned naps. How would you counsel this patient or any of your patients on the utility of naps? How would they take naps? Because you had mentioned that sleep hygiene is to avoid naps. Is there any utility?
Yeah, so naps, generally you want to preserve your sleep drive till nighttime so you get a better consolidated sleep at night. So I tell them to avoid naps, and those are the naps where you're dozing off in front of the TV or anything like that. But, some people really feel this strong urge to nap during the day. I can speak from experience, and you just have to put your head down. Or maybe you're trying to, you're planning on driving somewhere and you're just totally drowsy and sleepy and it's not safe for you to drive. In these scenarios, I do recommend that you take naps and prophylactic naps too before you drive. Generally, they should be kept short, 20 to 40 minutes. Those types of naps have shown to help with alertness for at least 2 hours after the nap. Anything longer than that, you risk what we call sleep inertia, sort of this residual groggy feeling for some period of time. And certainly you should expect that it interferes with your nighttime sleep if you're going to take a longer nap during the day.
When I was in the Air Force, some of the pilots, the counseling they would give to them is they can take up to 2 20 to 30 minute naps a day, and then they had some like high energy foods that they could eat. Think like handful of nuts or something, like almonds was like a stimulating food, and they had all sorts of ways they were trying to sort of like hack sleep, I guess.
Yeah.
But apparently, like, you just feel real groggy if you sleep longer than that, right? Like it's if you sleep less than 3 hours or something. I don't know what the cutoff was exactly, but if you have like a nap that's like too long but not long enough, it might make you feel worse. Is what they told us.
Yeah. No, you're right.
So let's see some. I don't know that you want to get it, Paul. Do you want to get more into like the mechanics of CBT, or you want to move on to some of the like over-the-counter meds?
Oh, let's just cut to the pills.
What do you want to do?
Let's move on to the Z drugs.
The Z drugs.
Yeah.
Good.
So he actually wants to know about Z drugs at this point. What is the utility? Is it are there benefits? Are there risks?
Oh, for sure there are benefits and risks. The Z drugs are the non-benzodiazepine hypnotics, Ambien, Lunesta, Sonata by their brand names. They are generally used, or I generally use them for short-term use for insomnia, usually acute insomnia. Again, I just want to emphasize that the first-line therapy for chronic insomnia should be, CBTI. We may use sleep medications as an adjunct or as a bridge, perhaps, but generally I want my patients to be sleeping well on their own without medications.
So you say short term, is that up to 12 weeks? Is that 4 to 5 weeks? I think that's what they're FDA approved for, isn't it? Like it's short time.
It's very short. I think it's even shorter. I think it's like 7 days, I want to say.
Oh, wow. Okay.
Yeah, it's a matter of days, but that's not reality, right? We always use these medications. And
the person that's on like 12.5 of extended release Zolpidem for like the past 10 years, I tend to see that patient.
Yeah, right.
And they're clinging to it, and they're clinging to the medication.
Yeah. Actually, when I was at Kashlak overseas with Kashlak military, there was one individual who had taken an Ambien, in this case not me, who was riding a bus naked and could not remember that the next day. So one of the things that I talk to my residents about is actually the Ambien walrus. I think it's pretty funny, but it's also a way to counsel your patients. And in my own personal story there, you can see there it says, couldn't sleep last night, so I took an Ambien, first time. What could be the harm? Woke up to 5 dirty tablespoons, a half-empty jar of family-sized peanut butter, and an empty jar of marshmallow spread. Now I know.
Gross.
That's really interesting. Yeah, as you know, the side effects of Ambien and the Z drugs is most worrisome is the parasomnias. They get the nighttime sleepwalking, sleep eating. I mean, we've had patients report they get in their cars, which is not a very good thing. I do want to make a note of Ambien in particular because it's one of the most common Z drug or sleep aids, prescription sleep aids out there, is that we have to be cognizant about using it in men and women because in women, actually, the studies have been mounting that's showing that women metabolize Ambien differently. So they're more likely to have really high levels after 8 hours to the point of impairment.
Wow.
They've done studies of driving simulation and shown that women with Ambien on board, from 8 hours ago, still have significant driving impairment compared to men. So actually the FDA came out in 2013 and recommended that for women, you should stick with the lower dose of Ambien, 5 milligrams, or the long-acting 6.25 milligrams. And these are young women too, not elderly women.
I feel like I remember there was a couple of meta-analyses that came out a couple of years ago that sort of looked at Zolpidem and some of the other Z drugs, and then actually just showed just increased all-cause mortality. And it didn't. I mean, it was a little bit dose dependent, but not so much. How wound up should we be about that kind of about those studies? Is those something we should take into consideration when prescribing, or do we have other more realistic concerns like sleep driving and sleep hot dog eating,
or sleep peanut butter eating?
Yeah, I think I've seen that data, and there's some data suggesting that it might be related to dementia, cancer, but I don't think it's such hard, fast data that it's really changed clinical practice so much, and we still prescribe it, again, with the idea that hopefully it's a short term or a bridge to CBTI or better sleep habits.
And I think, and then I'm sorry, man, I don't mean to beat this to death, but I think one of the themes of this show is us sort of selfishly using it to then inform our own clinical practice when we don't know how to do something. So for the patients that come to you who have been on Zolpidem for a bazillion years, and it's just that the Rubicon's been crossed, do you have any practical tips in terms of how to kind of get the patients off of that, or do you even need to try at this point? Is it worth even trying to pursue that? Yeah,
actually, studies have shown that CBTI can help with people, decreasing the dose or de-escalating or getting off of chronic sleep aids. And so I think CBTI is a great option for patients who want to try to get off Ambien, chronic Ambien. And oftentimes at that point, if they've been using it for 10 years, 20 years, it's really probably not a physiologic effect and more of a psychological effect. I actually had a colleague who had a patient, she was telling me that, they were working on weaning off the Ambien and she was doing very well with CBTI as an adjunct. And she came to a point where, she still needed that Ambien by her bedside. But all she would do is lick it and put it by her bedside. And it was highly effective, but that's sort of the lowest they could go. So she took it, that's fine if that's what you need.
That sounds like a wild success story.
It's like that colleague. It's the Winston Churchill martini where you drink gin and then look at vermouth.
I wanted to ask you, we're going to ask you about a bunch of meds, and we're going to open up to the audience for questions in a bit here. I wanted to ask you, is there anything that you've learned about sleep or sleep medicine in the past couple years that have really surprised you or changed your practice that you wanted to share with the audience?
Yeah, my area of interest is really phenotyping sleep disorders, and particularly sleep disordered breathing. And what I've come to realize is the way we define disease is very important in the type of people we capture and diagnose, and even studies and outcomes. So for me, a concrete example would be sleep apnea in women. The way we define OSA right now is basically by an AHI, right? It's one number. How many apneas, hypopneas are you having per hour? It's such a gross metric, and we bucket patients based on this metric, but it turns out that that's probably not the most important thing in terms of health and treatment and outcomes. And so for women in particular, their sleep apnea looks different than men. Women are more likely to have what we call REM predominant OSA, so they have a lot of sleep apnea during REM sleep. And why is this important? Well, just studies in the past 3-4 years have come out that suggest that all that cardiovascular ill outcomes that we're seeing associated with sleep apnea may be more related to REM sleep apnea. And so that means, when we compare men to women, men traditionally are at higher risk for sleep apnea as defined by total AHI, and they do have more sleep apnea during non-REM sleep. But when you look at REM sleep, men and women match for age and match for BMI, they actually have equivalent severity degrees of REM AHI. So now you have this whole group of category of people, women in particular, who may be underdiagnosed or undertreated because we're not looking at the REM AHI, we're looking at the overall AHI when we decide to treat patients. So I think that's where my work is really, and my interest in the past 3 to 5 years. I hope to better service people with sleep disordered breathing by figuring out how it affects differentially different categories of people.
I guess at this point, are there any specific treatments to target, like REM, the improved sleep apnea during the REM periods of sleep?
Yeah, there's no specific targets now. Right now, it's CPAP. That's the main go-to. I mean, I know that they're developing medications to treat sleep apnea, if you believe that, and we'll see it down the pipeline. But nothing targeted to REM OSA.
Okay. The other things that we wanted to ask about, I mean, there's a lot of questions about the various drugs, but before I forget about it, I wanted to find out if in your practice, have you found any of the sleep trackers? I know they make like a ring that you can wear, the watches, and I've heard maybe even mattresses are going to track our sleep in the future. What are you using any of that? Do you think it's helpful, or is it just kind of...
Well, so there are a lot of commercial wearables, as you say, or trackers and apps that measure sleep. And actually, there have been some studies comparing these, and some of them are pretty good at detecting sleep. So the Fitbit 2, I think it's called. I'm blanking on their names. The Dura Ring, the Sleep Smart, I think it's called. There are definitely many apps out there that claim that they can measure sleep. And it turns out in these studies, and there are just a few studies as of last year that compare these devices, they're pretty good at detecting sleep, but poor in detecting wake. So the device might say you're awake, but you're really actually asleep. And on all of these devices are really poor at detecting the different sleep stages. So they claim to know when you're in deep sleep versus REM sleep. Studies have just found that that's not accurate at all.
So you could be driving yourself crazy if you're one of those people that looks at the numbers and is like someone checking their blood pressure 100 times a day and it keeps going higher and higher.
Yes,
like,
exactly.
Why is my sleep getting worse and worse?
Yeah. Yeah, it's not uncommon to have a patient come in and, you're asking them questions, they feel great. Yeah, I go to bed this time, wake up this time, I feel great. So why are you here in my office? And then they'll pull out their phone and say, my phone is telling me I'm not sleeping well.
That reminds me, my iPhone claims that it blocks the blue light. And does that mean I can just read in bed? Or Kindle, all these things.
I mean, these are better options. Blue blocking, devices, or those blue blocking glasses that they have. They are better than not having them in terms of light exposure and potential for keeping you up and delaying your circadian rhythm. But really, the best way is to minimize your light exposure, having dim light during the nighttime.
Okay. So paper books by candlelight.
Old school.
That's what it is.
They didn't have sleep problems back then.
My house burns down. Well, how are we doing time-wise, gentlemen?
We're at 8:15.
Okay, so we can. I would like to give the audience the chance to ask some questions. There's a mic there and over there. Maybe not over there. There's a mic there. So if anyone has questions, if not, we have a bunch of questions from Twitter that we can go through. Not surprisingly, there's definitely a question about CBD oil, but we'll see what the audience. We'll see what the audience has to say.
Not from Twitter, just from Matt.
You sure it's not you, Paul?
My whole suitcase is filled with CBD oil. All right.
Hi, my name is Sarah. I'm a resident at Mailer. So my question was, so our society is increasingly depending on like alarm clocks to wake up. So what are your thoughts on that? Because it disrupts like the stage of sleep we wake up. It's just naturally sleeping and waking up in that normal stage.
Yeah, I think what you'll find, I mean, I think we all need alarm clocks, unfortunately, because we have to be on schedule. But what you'll find is if you stick to a regular schedule and your alarm is set at the same time every day, maybe 3 or 4 weeks into this habit, you'll find yourself waking up much more easily at that time that you're set your alarm to. You'll probably be sleepier sort of 8+ hours or earlier, so you'll have an easier time getting to sleep. And if you allot yourself 8 hours of bedtime, then you're guaranteed to get normal sleep architecture and normal sleep.
That kind of begs the question, what if you wake up like an hour before your alarm goes off, and you're like, I could get up, I feel okay, but I'm going to go back to sleep.
Yeah.
What are your thoughts on that?
So I would base it on how much sleep you just got prior. So if you're waking up after 2 hours of sleep, you probably would benefit from that extra hour of sleep. But if you've been in bed for like 7.5 hours, and if you wake up and you feel great, then I'd say go with it and wake up and start your day.
Hey, how's it going? My name's Kellen. I'm a current sleep fellow. One of the things that I've noticed in my practice, which is something that I sometimes have struggled of exactly how to handle the situation, is kind of cultural sleep issues. Right now I'm doing a pediatric rotation, so co-sleeping is something that I've seen parents do, and their bad sleep is fragmenting their child's bad sleep. And then I guess maybe more in the adult population would be somebody that says, culturally, I have always taken my siesta. You're telling me not to take a nap, but that's something that in my culture I do. What are your strategies in taking an approach to this? Yeah,
that's really a great question. And I think, there is more interest in understanding sleep disorders, sleep complaints in different cultures, different races, ethnicities, as well as gender and different age groups as well. And I agree. I don't think one size fits all kind of strategy. So I would listen to the person's sort of cultural background and even daytime needs. Sometimes you're even dealing with people, because of necessity, who are shift workers or who have irregular sleep habits, and sometimes you have to just work around that. So I'm not pretty militant about no, you can't sleep with your child, or you can't have your siesta. But I would listen to what their goals are, what their lifestyle is, sort of what their routine is, and sort of build my sleep strategy based on that. So in terms of co-sleeping, it can be disruptive, but you probably can have them do environmental modification to make it less disruptive. Siestas, again, you can I wouldn't say you shouldn't do a siesta, but maybe keep it short, maybe earlier in the day, maybe right postprandial, kind of where you get maximum benefit. These kinds of things. Yeah.
You guys have any favorite questions from the Twitter cohort here?
Since it came up, there's actually a question about shift work, and particularly our patients who work nights. I guess the general question was, what kind of anticipatory guidance can you give those patients, and what kind of counseling do you do about the known cardiovascular risks, which I feel like is kind of unavoidable, maybe, but you would know better than I. So what do you tell those patients who work nights?
Yeah, surprisingly, 10 to 15% of the U.S. workforce are shift workers. And shift work has been shown to be associated with more cardiovascular disease, but also cancer, surprisingly. And it's been actually shift work has been declared carcinogenic, probable carcinogenic. Oh, yeah, newsflash to all the residents out there. But we're a 24-hour society. We need shift workers. So how can we help them improve their sleep and improve their functioning during work time? So, if they can't, I always first ask, about, are there other options? Can you move to the daytime? But if that's not an option, then, there are strategies. For example, if you're going to do irregular shift work, you can ask your manager, for example, to put you on this clockwise rotation, so that's a little bit later. You're taking the later shift works sequentially, so that you can sort of adjust that way easier. I also talk about, how to keep a regular sleep schedule during your work days and your off days, because that'll help you cope better and get better sleep when you're trying to sleep during the daytime, for example. You're never going to get the best quality of sleep when you're a shift worker. You can try to adjust your circadian cycle to sort of correlate, but it's not going to maximally correlate to your shift work, especially if you're a third shift or a night, a full night shift worker. So they might. So I'd say come home, put blackout shades, minimize your light, wear sunglasses as you're walking around during the daytime, really try to fool yourself that the daytime is actually your nighttime. And then they'll probably get 4 or 5 hours of sleep when they come home from work, and then, they go about doing their daily activities. And then I also say, maybe take a 2 hour to, if a little bit longer right before you go to work, to optimize your performance. And then you tell them, make sure you're doing your critical tasks earlier in your shift, when you're more likely to be awake. Also, if you have breaks during the night, to use them and take short naps as ways of coping. Also, moderate caffeine use during the nighttime can help with nighttime performance as well.
Yeah, it seems like a tough thing. I mean, they've got to. Some people just have no choice when it comes to that.
What is moderate caffeine usage?
Yeah, it's intentionally left subjective, because some people 1 cup of coffee and they're bouncing off the walls.
We've covered this many times on the show.
Yeah.
The answer is as much coffee as they want. It's never been shown to be harmful in any way.
Yeah.
So I think they're good.
Yeah.
We did have a bunch of questions. This is one from Philo Elwood. Says, does melatonin work? Just open-ended, but maybe I'll direct it a little bit more. If you are going to prescribe melatonin, who do you prescribe it to, in what dose, and when do you tell them to take it?
Yeah. So melatonin is really, it's obviously one of our organic hormones that we secrete during the night. It helps regulate our circadian rhythm. So I mostly use it for treating circadian rhythm disorders. But as you know, it's over the counter, and people use it a lot as a hypnotic to help them fall asleep. The dosing that they do off over the counter is actually really super physiologic. 3 milligrams is probably the lowest I've seen, but they sell in 5 milligrams and 10 milligrams. But you really only need 0.5 milligrams, so 0.5 milligrams to have an effect on your circadian rhythm. So, we're talking whopping super physiologic doses of melatonin that is being used. When
Night Float gives my patient 10 milligrams of melatonin at 3 a.m., it's not good for them?
Well, it's probably, I don't know if it's good or not good for them, but they're definitely getting a whopping dose of something.
Yeah.
The way I use melatonin, again, is for shift work, but circadian rhythm disorders. But if you're using it for, or if the patient is using it for insomnia and is insistent on using it, I would just make sure they're taking it at the same time every night. Because, the way you get in trouble is they take it, at 8 p.m. one time, at 11 p.m. the other night, and then, 1 a.m. the next night. Then what you're doing is really foremostly affecting your circadian rhythm, and you're going to have more trouble sleeping. In general, in terms of safety profile, I don't think we have really good data. In fact, if anything, the lack of melatonin may be of concern. Melatonin decreases quite a bit with age, and especially in women after menopause. And that melatonin decrease has been linked to maybe LH surges that might induce hot flashes, for example, and disrupt sleep. So if you give melatonin to postmenopausal women or menopausal women, it doesn't really decrease their hot flashes, but it's been shown to improve their mood and their sleep quality for what it's worth.
Kind of a piggyback question. Have you ever used or seen patients that are using 5-hydroxytryptophan, which provides a donator molecule for serotonin and thus melatonin?
Yeah, I mean that's the concept, right? It's a precursor for serotonin and melatonin. I don't know what to say about that. There's not much data. Let's say it works for some people, then I let them continue with it. If it's not working, and truthfully, most often it's not. It's just something else they're desperate to try and to use. I would help tell them, we have better options than that.
Does melatonin cross the blood-brain barrier by itself?
Does exogenous?
Melatonin, yeah, exogenous.
Exogenous.
Because I know 5-HTP does. I'm not sure about melatonin.
Yeah, it has to because it's affecting the your circadian rhythm. So yeah, I'm envisioning that it does because it's releasing the pineal gland for, endogenously.
Okay. Oh, it looks like we have a question, and then we'll have to start to wrap up. Yeah.
It's a piggyback question. Is there a particular brand of melatonin?
Oh my God! I was so afraid someone was going to ask that.
Thank you, sir.
Actually, I personally don't have a brand I know of, but we actually have a list in our center for our patients that our pharmacists did some research on. Because you're right, a lot of them are, they're not FDA, cleared, and they're sort of God knows what else is going on in those preparations.
Melatonin in each pill in different companies ranges from 0 to 300.
Yeah, you're absolutely right. There's no regulation for it. So I have a pharmacist who has a nice list of brands to give to patients, and if you want to catch me offline, then I can try to get that for you. But I'm sorry, I can't spew out the names right here.
Unless you're going to sponsor us, I think that's
Okay.
Our sponsor's MyPillow.
Do we have time to sign off?
Sure.
Okay. Paul, you want to do the honors?
Let's do it. Oh, so first of all, thank you so much. This is spectacular. But this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole. Get your show notes at thecurbsiders.com/podcast, or sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
That's right, Paul, because we're committed to providing you with high-value practice-changing knowledge. And to do that, we need your feedback. So please subscribe, rate, and review the show on iTunes. Is iTunes still a thing?
I think they're phasing it out, actually.
Yeah. So on whatever you use.
On Apple Podcasts.
That's right. Or contact us at thecurbsiders@gmail.com. A special thanks to our producer for this episode, Sarah Phoebe Roberts. Thank you, Sarah. I don't know where Santa came from. And his elves. And to our social media team, Hannah R. Abrams on Twitter, Beth Garbs, Garbatelli on Instagram, and Chris the Chew Man Chew on Facebook. Until next time, I've been Stuart Kent Brigham.
And I've been Dr. Matthew Frank Watto, and thank you to Stuart for the theme music, which will in post be playing over top of our voices right now.
Great, you guys.
Our great guest, you want to sign off?
Sure. This is Christine Wan. Thank you for joining me, and this has been very exciting. Thank you.
And I remain Dr. Paul Nelson Williams. Thanks. Bye.
Oh, hi, Paul. Hey, Paul. I got a pun for you.
No, you don't.
Got it.
Okay.
Kill the mics.
I had one, but I'll sleep on it.
Thank you for the fake laughter. Yeah. All right.